hardest part for me, the hardest part for me with shoulder stuff, shoulder girdle problems, is looking at the differential diagnosis stuff, determining what is the pain producer. That's usually going to be the biggest issue that I have going into things, because essentially what you really want to do is you want to figure out what structure it is that's actually producing the pain. That gives us a bit of a kind of lead in to what potential dysfunctions might be causing this, right? So etiology wise, if we start looking at, oh, well, it's a biceps issue, we're typically going to look at some sort of impingement problem. If we're looking at AC joint pain, we're typically going to be looking at some sort of upper thoracic issue. Essentially this is kind of how you start to view these dysfunctions, as you'll see, well, this structure is painful. That tends to mean it's, and it's with this particular activity, it tends to mean our problem is going to be coming from over here. The shoulder examination process can get a little lengthy. It can get a little complicated. The way I was taught it is clearing the cervical spine first, to make sure that you're not dealing with any type of referenced pain. I don't do it that way anymore in the clinic, because essentially what I should be seeing, if we're dealing with a referenced pain, essentially something coming directly from a somatic or even a neurologic structure in the cervical spine, you're going to have pains in more areas than just in the shoulder, more than likely. Probably the most common thing that you deal with is kind of upper scapular pain. It's probably the most common thing that you'll deal with going into the shoulder girdle from the neck. I've been in my office for several hours now, and I've already seen 4 of those today, where we're dealing with levator dysfunction, levator discomfort coming out of a cervical spine problem. Mostly that's going to be because the levator is innervated by C3, C4, which essentially means C2, 3, C3, 4 are going to be the segments within the cervical spine that are dysfunctional, that are irritable, that sort of thing. And those just tend to be the 2 most commonly irritated segments of the cervical spine, especially post-traumatically. They tend to be. Now, degeneratively, that may be different. 5, 6, 6, 7 tend to get more degenerative changes, simply because of the curvature there, the thickness of the joint structure, and then essentially the rigidity of the thoracic cage beneath that, particularly if we're looking at somebody with CT junction problems. That tends to be where we take up those slack, that amount of slack. So the process can be very linear, right? So the first thing you want to look at is you want to look at movement patterns of the shoulder. You want to look at, essentially they end up being combined movements. Yeah, certainly have to agree with the levator symptoms with upper cervical stuff, definitely. When we're looking at movements of the shoulder girdle, as far as examination goes, we're really going to be looking at things that are more combined movements than isolated movements. Okay, so we're not looking at pure abduction. We're not looking at pure plane flexion, things of that sort of nature. We're looking at elevation through flexion, abduction, and external rotation. Okay, that's really the combined movement that should be occurring at the glenohumeral joint, but it also will incorporate movements of the scapula. It'll incorporate movements of the clavicle, and then also of the CT junction, upper thoracic region. Okay, so we're really looking at this almost as one of our screening tests, right? We've talked about this plenty going through module 4, module 5, about screening tests that should clue us in that there's actual dysfunction in these regions that we have to go in and investigate more in depth. And essentially that's going to be one of those things. Okay, so overhead reach or elevation of the arm overhead is going to be probably job number 1. The second one is going to be the kind of the reverse of that. That's going to be extension, internal rotation, and adduction. Essentially put the hand behind the back. And you can accomplish both of these things in the same movement, right? So these are the ones where you're going to try and reach one hand behind the back and reach one hand over the head, which I am physically incapable of doing. So somebody else, if they want to demonstrate that, will have to demonstrate it for me. Where you're looking for some sort of discrepancy from left to right. Okay, that's going to be basically our functional test. It kind of mirrors like our squatting, axial rotation, things like that we'll do in the lower quadrant. Okay, so that's step 1. Once we find that and we start saying, okay, say the right side is dysfunctional, then we have to kind of start breaking things down into components. So from there, I will typically go straight to the most proximal structures. I'll go to the CT junction. Really shouldn't have to spend a lot of time discussing CT junction examination. You guys should be getting pretty good at that by now. I'm certain it'll be something that is reviewed again during Module 6, just because hard to examine the shoulder girdle without having the basically the foundation be properly examined. Essentially, the only connection that we have to the trunk via the shoulder girdle is right here at the sternoclavicular joint from an articular perspective. So that means sitting on top of the ribs. If the ribs are dysfunctional, it's going to create dysfunction moving outward more peripherally into the shoulder girdle. From there, I'll move out and I'll examine the shoulder girdle itself. So when I talk about that, I'm looking more at the AC joint, SC joint, depending on the amount of movement that's lost here. So for the AC joint, very simple two tests that I'll run for the AC joint. Horizontal adduction, right? So crossing across the chest, and then abduction of the pure abduction of the shoulder girdle like this. Both of those movements, if there is a mechanical loss of movement at the AC joint, will be substantially limited. Okay, and you should be able to compare that to the opposite side and figure out whether or not that's the case. Okay, so that's a good way to kind of rule that in as another region that you have to go in and examine more specifically. Getting into the glenohumeral joint, at that point, you can take them through more cardinal planes of movement. That would be things more like straight abduction, more straight plane flexion, external, internal rotations. I tend to do those all passively. So when I'm laying a patient down in supine, that's more where I will do that sort of stuff because I have a better chance of fixating the scapula with the weight of the body laying on it. That should be something that we'll explain and go over during Module 6 as far as passive mobility testing of the glenohumeral joint. But that's typically the next kind of step in that process. After that, we have to get into actual movement, flexibility, mobility of the scapula itself. Right? And so the scapula is, when we look at scapular kinetics, right? And this goes back to a lot of the things that we read in the literature talking about scapular dyskinesia, right? So abnormal scapular movements. We're really looking at muscular problems, right? So this is something that's going to be affecting tone of the periscapular muscles, right? So we're looking from this perspective, we're looking at things like the levator scap, the rhomboids, serratus anterior, lower half of serratus anterior. We're looking at the lats. We're looking at pec minor, that type of the upper portions of serratus anterior. These are the muscles that are actually going to create movement of the scapula with things like elevation of the arm overhead. This can get very complex if we want it to be, but it doesn't have to be, because essentially what we should have with scapular mobility is quadrants, right? We should have things like protraction and elevation. We should have things like elevation and retraction, protraction and depression, and then retraction and depression. And with each one of these quadrants, we should be assessing the flexibility of the various musculature that is actually associated with limiting that movement, right? So the most common one that we're going to deal with, again, is going to be levator scap. That's going to be assessed via, make sure I'm getting this right inside my head, depression and protraction. When we're assessing the pec minor, which would probably be the second most common one that's going to affect scapular movement, it's going to be depression and retraction. For the lats, we're going to be dealing with protraction and elevation. And then with the levator, not the levator, the serratus anterior, we're going to be dealing with elevation and retraction. Okay, now there is a fifth mechanism where we actually have to assess winging of the medial scapular border, medial scapular angle for the upper half of serratus anterior. Again, these are things that'll be demonstrated in the clinic during the course intensive. There's just no real good way of me showing you how those things look without a patient here in the clinic to show you that stuff. So you can write it down. And we can, here as we go along, I can type that stuff in if we need to have it more, kind of delineated on paper here or in the chat. That might be a little bit easier than listening to me talk about it. But that's what we're essentially assessing. Now for the rhomboids, we're probably going to assess a pure protraction moment in order to try and kind of take the medial border of the scapula away from the spinous processes, essentially the central portion of the spine. The problem with that one is that it also will assess protraction of the articular components of the SC joint, right? So when we're looking at scapular movements versus SC joint movements, think of it like this. The SC joint movements are going to be more assessed with cardinal plane movements: elevation, depression, protraction, and retraction. That's going to give you a better assessment of SC joint movement. And then these oblique movements where we get, say, elevation and protraction together, that's going to give us a better feel for what we're feeling as far as extensibility of the parascapular musculature. Now, there are combined movements of the SC joint that have to be taken in consideration: protraction and elevation, depression and retraction, that are used more as a roll of the clavicle. But those are more articular tests. Those are done more with your hands on the clavicle as opposed to your hands on the scapula. So again, during the course intensive, you guys will have a lot more chance to kind of differentiate between those things, get a sense of how you're using end feel with that. Again, when you're accessing these quadrants of the scapula, you should be feeling for muscular end feel versus when you're doing movements of the SC joint, you're going to be looking for more articular type end feels, which may be anything from capsular to pathomechanical to springy to any of those other ones, that capsular, et cetera, that we're going to be dealing with potentially in an articular structure. So that's kind of the next step there. When we're looking at the nice thing about doing that, about going in and examining the extensibility of the parascapular musculature, is it actually clues you in very specifically to what level of the cervical spine might be dysfunctional, if there is indeed a problem coming out of the cervical spine. It kind of operates a bit like a clock where we're going around the scapula. So for instance, if you're looking from behind at a patient and you're looking at their left scapula, the levator starting top right at that point is C2-3 from a neurologic input, right? C4-5 is going to be your rhomboids. C6 is going to be your lats, and then also your lower portion of the serratus. C7 is going to be your pec minor and the upper portion of the serratus. C7, C8, right? So we kind of wrap all the way around in that particular position. If we're looking at the backside of the left scapula, it's going to wrap clockwise around the scapula in order to find what particular level might be dysfunctional. And again, tone is really the big issue here, right? If we have increased tone in any of these particular muscles, essentially we're missing a particular quadrant of the scapula, right? So for instance, if we're looking at the levator scap, we would have to depress and protract the scapula. If we're missing that particular quadrant, we would expect C2-3, C3-4 to be some sort of dysfunction, right? So missing that means increased tone, probably means what? Facilitation, right? Increased tone with facilitation, decreased tone with AXT problems, with radiculopathy problems, right? So that's an easy way to kind of look at that sort of thing. What could possibly be causing that sort of stuff? Depending on if you have too much tone or too little tone, that's the way you have to kind of focus on those sort of things. And then all you have to do from there, in order to ensure that it is indeed a segmental problem, is you want to move to a peripheral muscle that has a similar innervation, right? So say we're dealing with issues with C7, so we're looking at maybe pec minor being hypertonic, not allowing good depression and retraction. At that point, we would just have to search out a peripheral C7 muscle, right? So triceps, wrist flexors, finger extensors, any of those things would play an equal role in looking at potential segmental facilitation. Okay, so when we're talking about scapular dyskinesis, right, we're dealing with the idea that the scapula is just not moving the way it's supposed to. It's not contributing to these functional movements, elevation overhead, or extension, adduction, those sort of movements. We can look at these particular things as being the causes, right? We're dealing with improper movement of the scapula due to muscle tone changes. That's the true dyskinesia diagnosis that I would come up with, as opposed to some sort of fixation, right? When we're looking at articular fixation of the scapula, there's really not a whole lot that can go on outside of it just being at the AC joint, right? That makes sense, because that's really the connection. Any questions about that sort of stuff? That's basically the diagnostic criteria. If you do find that you have some sort of segmental issue, by looking at your scapular musculature there, looking at the length of those scapular muscles, now you know you have to go back and you have to examine the cervical spine if you haven't done so already. Okay. No questions? Nothing burning a hole in anybody's head right now? Okay, we're going to move on then. When we're looking at etiology then, right? So we have now kind of a process at least outlined in place, right, of how you go through and examine these things. Functional task first, then break these things up into different components, right? Look at glenohumeral joint mobility, look at glenohumeral joint stability, look at scapular mobility, look at AC joint, look at the CT junction. And if we have to, based on our exam throughout this mechanism, we go back and look at the cervical spine. And again, there may be points in time where you're dealing with things that are into the neck that you have to deal with the cervical spine ahead of time. That certainly happens plenty of times. But etiology is really where this stuff becomes, more interesting when it comes to the shoulder girdle, right? So probably the most common complaint, at least that I get in clinic when it comes to shoulder issues, is going to be anterior shoulder pain, right? It's going to be somebody comes in saying, I've got pain right here. It's with X, Y, and Z activities. Typically, it's with some sort of carrying, some sort of reaching, particularly overhead, that sort of stuff. So you get suspicious of some sort of impingement, right? The idea at that point is you tend to have to come up with a few different possibilities, right? These are your differential diagnoses, right? So what might be, you guys can put it in the chat. You can just jump in if you want to here. So we're not just listening to me talk the whole time. What would be, 3 potential possibilities as far as diagnoses for anterior shoulder pain? Who's got some answers for me?
Anterior labrum could be one. You could have biceps tendon, AC joint on top.
I like it. That's all easy stuff, right? I mean, you run through that, you already got 3 options, right? AC is pretty common. Labral pathology is pretty common. Biceps issues, right? Now, the biceps issues can get more complicated because we can actually deal with bicipital groove problems as well. That could include things like the transverse ligament that goes across the bicipital groove. We can deal with things like pec major tendinopathies, because that does cross the bicipital groove and attach to the lateral edge of the bicipital groove. The lat, same sort of idea, only on the medial side. And we can certainly have things that might manifest anteriorly, like corticoclavicular ligament problems, things of that nature. But these are things that kind of drop down the list from a probability perspective. So when you're looking at that, then you go to your next step. Biceps long head, we have tests for that, right? Biceps load tests works very well. Basically, you get the arm in neutral, about 30 degrees of flexion, 30 degrees of abduction, and you resist the biceps, right? Have them resist against that. That should reproduce discomfort, okay, if the biceps mechanism is painful. After that, what you're going to want to do is you're going to want to drop the elbow posterior to the trunk, right? And that's going to seat the biceps tendon within the groove more naturally. If you resist again and the pain disappears, you're more likely to be dealing with a transverse ligament injury or maybe even a pec major tendon injury. Because what happens here with the elbow into flexion is the biceps tendon will actually bowstring into those supportive structures and will cause problems there. When you seat that biceps tendon posteriorly into the groove and you reproduce it, it'll no longer put pressure into that transverse ligament or into the pec major tendon. So it's less likely to the biceps itself, more likely to be some of the support structure. I'm sure Dave's got that. We've got all this stuff written down anyway, so this isn't all the course material. So again, at that point, you're looking at differential diagnostic processes, right? If it's not painful to begin with, you don't have to go any further. You move on to the next one. Stressing the labrum, load and shift works very well with that. For me, I have no problems there. You can do a scour, you can do any number of those sort of things. Quadrant testing works very well for doing that also. And then the AC joint becomes very easy. Palpation is by far the most effective way of finding out if the AC joint is the pain producer. Pro tip though, when we're doing palpation for the AC joint, the easiest way to find that is, instead of getting onto the top of the joint line, is actually to slide posterior to the head of the clavicle and drop into that little V shape between the spine of the scapula and the posterior element of the head of the clavicle there, or of the end of the clavicle there. That's the portion that will tend to be the most painful and most likely to reproduce pain. Okay, so that's just a little hint when it comes to checking the AC joint. So any one of those things gives you a particular diagnosis, says, okay, I've got AC joint dysfunction, I've got biceps issues, whatever that may be. Now I'm looking for etiologies, right? So this is where things can get really complex, where you can really have to start looking at various other body regions that may be affecting things. I think Jim has some things outlined as far as, you know, neurological dysfunctions, neurophysiologic dysfunctions, and then mechanical dysfunctions. And then there's also structural dysfunctions that you may have to think about, right? So a destabilized or a non-intact labral structure can also cause biceps issues, right? That makes a lot of sense. But as you start breaking it down by these sort of components, neurological issues, okay, you know, what might be causing that? At that point, you're looking at either AXT problems, which may include peripheral innervations, or you're looking at nerve root problems, which would be more radiculopathy related. So you have to do your neurologic testing at that point in order to determine, is this segmental or is it peripheral? Should be getting better at that stuff as we go along here. And if you find something there, then you're on to, you know, what's causing this neurologic issue. Segmental, probably something in the spine. If it's more peripheral, you may be looking at either something underneath the clavicle as it goes into that subclavicular space, which again, we'll describe how to examine for those sort of things more specifically. It's a hint. You're going to probably go through upper limb tension testing, or potentially some sort of double crush where you have something at the spinal column as well as peripherally. If you're dealing with segmental facilitation, we have our usual things that we need to look for there. What else can we use to decide if we're dealing with a facilitation? Anybody have a good list for me? Somebody's got to have something. Don't make me start calling on the fellows here, Tanners.
Reflexes, you can do sensation.
Okay, good. So this is a pretty common answer.
Right?
Say that again, Tanner. I didn't get that.
You'd also see velocity dependent weakness, right?
Yeah. So, and again, going back to what Dylan was saying, if you're looking at sensation and reflexes, I get this all the time during exams. You got to tell me what's going on with the reflexes and the sensation, right? Same thing with strength testing. You can't just say strength, sensation, and reflexes. You got to be able to tell me, because it's the responses that differentiate, right? There's a different response for facilitation than you would get for radiculopathy, right? Or for local dysfunction, or for regional dysfunction. All these sort of things have different responses for these sort of things. So Tanner mentioned with our strength testing, we would expect some sort of velocity dependence to the weakness, right? There would still be weakness, but it's due to increased tension across the muscle belly, which is why the velocity dependence becomes so important, right? So that's a good response.
The reflexes and the sensations would both be hyper, right? With the radiculopathy, they're hypo.
Okay, so let's dive into that a little bit, right? So if we're dealing with facilitation, right? The name alone should suggest that everything is wound up, right? But terminology wise, you got to be careful saying hyper, especially when dealing with reflexes.
Yeah, sorry, it's the brisk reflexes.
Brisk reflexes, correct,
And
right?
then
So
I'm blanking on what the name for the sensation was. I'm blanking on that.
it's just hypersensitive to non-painful stimulus, right? So you may have distributed discomfort through the dermatome. It may be sensitive to things like pressure, right? Maybe sensitive to things like stretch, things of that sort of nature. You may, if it's really bad, really wound up, you may have kind of this, continued constant, not constant, but continuous pain throughout the dermatome. Those sort of things are more consistent with facilitation versus something like a complex regional pain syndrome, something like that, where it's, this true hyperalgesia or allodynia, any of those sort of things that kind of crop up. It's just an increased sensitivity to non-painful stimuli. May even result in things like paresthetic changes as well. But again, it should be segmental. Okay, so that's the sort of stuff that you should expect to find, right? But you can't just tell me straight sensation reflexes, because it is really the response to those tests. The tests are correct, absolutely, but it's the response to those tests. That's what you're really looking for that'll differentiate between the two. Okay, so that's kind of our neurological, neurophysiological things, at least from a segmental perspective. Right, we can still have things as far as neurophysiological that'll affect the shoulder girdle from a local perspective, right? And these are the things where we're dealing with. I tend to break this up into force output changes. So these are things like velocity dependent weakness, fatigable weakness, braking weakness. Now, braking weakness comes along with local pathologies, right? Local articular pathologies or instabilities, things of that sort of nature. That tends to be the things that'll give us this braking type of weakness. It's very consistent, tends to be present regardless if we test it once or if we test it 10 times. It tends to present as a result of abnormal kind of mechanical feedback through the joint, right? So if we have, for instance, kind of the easy one to think of is a sublux talus, right? We're going to have weakness throughout the ankle, right? Probably in all four directions. Jim tends to think of it more as a PNF pattern that may be weaker. I tend to see it across all four directions. That's just my clinical observation. But what you'd expect is it would not be in a segmental distribution, right? So if you're looking at dorsiflexion and eversion both being lost, eversion L5S1, dorsiflexion L4, it's not segmental, right? At that point it's not. So it should be something like that where it's distributed across more than one segment, particularly in the lower quadrant, but also in the upper quadrant. So that sort of stuff in the shoulder girdle can be a bit confusing though, right? Because we can have dysfunction within the glenohumeral joint and it will give us weakness across the glenohumeral joint musculature. Shoulder internal rotation, external rotation, abduction, flexion, all of these different movements will probably show up some sort of weakness. Now we have to consider the AC joint, right? If we have dysfunction within the AC joint, what muscles will probably be weak? Probably the ones that cross that joint span, right? So we're looking more at abduction, flexion moments, probably less issues with internal, external rotation. But the bigger problem becomes when we're dealing with true regional problems. That includes things like upper thoracic dysfunction, right? Rib dysfunction, CT junction, facet issues. Any one of these sort of things can cause what I would typically term, and I don't think it's in our course curriculum like this, but I would typically term this regional inhibition. Okay, this is going to cause problems throughout the entire shoulder girdle musculature, right? So we can look at PNF patterns, right? Take the arm out here and resist this sort of moment where they're trying to hold their arm up and it's going to be weak, right? Now, will that always be the case with AC and glenohumeral joint dysfunction? It's tough to say because at that point you're dealing with whole regional problems. It's very similar to having weakness of hip abduction with an SI joint problem, right? Something like that. But the idea here is that you're dealing with poor anchoring, right? All this musculature that should attach to and need to anchor into the chest wall suddenly becomes inhibited, right? But it's not local, right? So weakness of the deltoids, for instance, with shoulder abduction will still be present even if I have a T2 ring lesion, right? We'll still develop weakness because now the ring is no longer able to anchor well enough to give the AC joint and glenohumeral joint a solid base, a solid foundation to work off of. Okay, so I tend to look at those things and describe them as more regional inhibition versus true reflex inhibition, which is something that would happen across one particular joint mechanism. For instance, with what we would see around the ankle. Everybody kind of understand that thought process. Now, is there a difference in how you would test those things? Braking weakness versus speed dependent, there's not. It's going to present very much like a braking weakness, more like a true reflex inhibition, because that's essentially what it is. It is a reflex inhibition, but it's coming from a regional source as opposed to a local source. Okay. I just want to make sure everybody's aware that that is a possibility, that you can have that same sort of weakness due to an upper thoracic dysfunction, even if the musculature does not cross that upper thoracic mechanism. Okay, so as long as everybody's comfortable with that, then I think we're probably happy with that sort of idea. Good there, Dave? We on track? You can just give me a thumbs up if you need to. It's like having a mime run the. Yeah, oh, we got it. All right, so let me give you guys a scenario. Okay, and this may be different than some of the ones that Jim has on his video or on some of the flow sheets that he's got going, but this is one that I see a ton in clinic, so I think it's a good one for you guys to look into and kind of start to understand. All right, cool. So I may at some point here share my screen because I can do just a little drawing here that I can show you guys. In fact, I'll share this one right now so that you guys can look at this and see it. Okay, so what we have here is very bad cartoonish sketch of the scapular mechanism, okay, with the parascapular musculature. So this would be looking at the posterior view of the left scapula, okay? So left scapula here, right? Left side. So up here, we have our levator scap, right? You can see the line of pull that it would create, right? Rhomboid, right? Major and minor. This would be our lats coming across. Again, this is going to be much bigger. It's going to come all the way down through here. Serratus anterior, you can see the line of pull that it would create. And then here, this dotted gray line is our coracoid process on the front side of the scapula, right? Hence the dotted line. We're looking X-ray through it here. And the blue lines here would be the line of pull for the pec minor. Okay, so when we're looking at problems within the scapular mechanism, as far as true functional issues, very typically we're looking at 4 particular muscles that are problematic. Well, 3 muscles if you're really considering major and minor rhomboids as the same sort of mechanism. Levator scap is number 1, by far going to be the most common one that you're going to see. Rhomboids going to be the second, and pec minor is going to be the third. Now, not necessarily in that order. I would say the pec minor is probably the second most common one, just because of its innervation coming from lower in the cervical spine, tends to get irritated when there's upper thoracic dysfunction, right? So, but this one is by far the most common. Okay, so let's do. How do I do a new thing here? Where's my button? All right, so we've got, oh, this is not good. Let's not do that. Let's do a dark color here, shall we? Here is our scapula. Same thing, left scapula, spine of the scapula here, glenoid rim here, okay? Left side, like so. Now, you have a patient that comes in with anterior shoulder pain, okay? And I'll go ahead and give you the scenario. The patient is a HVAC technician, does a ton of overhead work on duct work, right? A lot of screws, a lot of drilling, a lot of bending metal, a lot of all kinds of stuff like that. A lot of time up on a ladder with the arms overhead. Started having issues with this about 3 weeks ago, and has been getting progressively worse, particularly during the work week. Okay, so work 5 days a week, gets to the weekend, arm is usually killing them at that point. It's usually pain's about a 6 out of 10. Gets a couple of days off, tends to rest, not do a lot of stuff. Pain drops down to about a 2 or 3 out of 10. Goes back to work the next week, and then it just kind of builds back up over the course of the week back to that 6 out of 10. So when we're in that sort of scenario, we are usually going to consider that to be an impingement problem, right? A lot of time up overhead, a lot of time with compression here, potentially in the front of the shoulder. So we run through, and our first test that we do is a biceps load test, right? So we're right here, resist that, that reproduces pain, okay? Drop the elbow back, we resist the elbow again, right? So right here, we're resisting elbow flexion. Again, that reproduces pain. At that point, I'm very comfortable in saying that this is a biceps tendinosis, right? This is definitely a tendinopathy because of the results of that biceps load test. Okay, so if we're all happy with that, that's your diagnosis. Where do we go from here? Who's got an idea?
It says scapular mechanics.
Are you just saying that because I drew a scapula?
No, I just want to see if we're getting upward rotation of the scapula. That's really what I'm
Okay.
seeing. Bicep becoming overactive, trying to help with shoulder flexion. That's really what comes to my mind.
Okay, and that's not a bad thought. I mean, honestly, at this point, there's no real wrong answer, right? There's only hypotheses, right? So you could be certainly looking at something like that. So what's your test going to be?
I was just more looking for like observation type of things at that point. Like I just want to watch the scapula move behind, left versus right, see if I notice any asymmetries. I'll kind of like start looking there first before I dove in.
Okay. An observation is it's good. I mean, it's fine. Basically, the hard part becomes any type of measurable difference side to side, right? When we're just looking at positional palpation, things like that. So you say, okay, I want you to lift your arm up overhead, and you're just kind of watching, feeling for how that scapula is able to move. You have to be able to quantify that with the opposite side, right? And that becomes difficult to do at times. So if you're looking at pure scapular mechanics, I would say the more efficient mechanism by which to test whether or not the scapula has dysfunctional movement patterns is to test the scapular quadrants, right? Which is something you guys haven't done yet, at least in the Illinois and Chicago groups. We haven't gotten to that, but going through and looking at that will give us an idea. Do we have, sorry, I'm pointing at the screen that you guys can't see me pointing at. Do we have loss of, depression and protraction? Do we have loss of depression and retraction? Where these certain things are going to become problematic. So that's certainly a test that you can definitely do, and you will learn to do when we get to the course module. I would say, and I think it was pointed out, I think Jenna pointed it out here in the chat, the easiest thing to do, and the one that you're really hoping for, is to look for more mechanical problems, right? So looking at CT junction mechanics is usually going to be my go-to to do first. because I'd prefer being able to fix a biomechanical dysfunction at the CT junction than have to open this can of worms with dealing with the neck off the bat. That's just a personal preference. And you see enough CT junction mechanical problems that from a probability perspective, it's probably going to be number one anyway. Because even if you have cervical spine dysfunction affecting these scapular mechanics via the parascapular musculature, odds are there's a CT junction issue that's contributing to the scapular dyskinesia, the cervical spine dysfunction that's affecting those parascapular muscles. So that's the first place I go. I'm always going to go look at the CT junction first from biomechanical perspective. Then from there, I'm going to shift out and look at the AC joint mobility. So I'm going to do these cross adduction, abduction, and then I'm going to do glides, which again, you guys will learn how to do in the course. Because I'm just going to take those biomechanical factors and take them off the table if there are none. Because that's easy for me to do, especially when I have a patient already and seated and I'm going through functional tasks. Dave, maybe you can throw in the chat what your process is there if you have a different thing that you go through and do first. Keep waiting for Dave to kind of do the he's in a box thing with his miming. That's right. Pull the rope. There we go. Here he is. Yeah, okay. So he does cervical first, which is fine. I don't think there's a right or a wrong answer here. The one thing that I would suggest is asking the patient during your initial evaluation component here, have they had previous cervical dysfunction? Have they had previous cervical trauma, which would include motor vehicle accidents, skiing falls, any of that sort of stuff, slips on ice, or if they have any other painful regions, right? Because when I evaluated this patient that we were talking about, anterior shoulder pain worsening over 3 weeks, I asked that patient, do you have any other body regions, any other regions within the shoulder girdle, within that side of the body that are also bothering you? They said, yeah, I have problems right here, right? Always feels tight. Always feels painful. They even mentioned to me that they get little paresthesias in this area at times, particularly when driving from one job to the next. Okay, so in this general vicinity, what's our first thought as far as potential contributors? Dylan, this will kind of go back to what you were talking about.
Well, the levator scapula attaches there. So
correct.
With elevation of the scapula.
Yep. So we're thinking levator scap potentially as a contributor based on that attachment point, right? So from there, again, my easiest test for this is going to be palpation. Dig my finger right into that medial scapular angle, see if it reproduces discomfort. If it does, okay, now I know I need to test the length, the flexibility of that particular muscle, which again is going to bring me back to my scapular quadrants. So I do that and I say, yep, that definitely feels limited compared to what I would expect. And again, we'll talk about expectations for the amount of movement you should get with these combined movements more consistently in the classroom. Right now, we'll just you take my word for it. It was limited. Muscular end feel. Okay, so now I have potentially 2 levels of the cervical spine, C2-3 and C3-4, right? Because we're dealing with the bottom level of the movement segment is going to be the one that supplies the nerve, right? So between C2 and C3 is the C3 nerve root. C3 and C4 is the C4 nerve root, right? So that's what we're looking at potentially as cause tone here. Now, let me go through and kind of explain to you guys how this transitions out to the bicep. Okay, so the levator here, let's just go I'll make this a little smaller so that you guys can see it a little better. Almost had it. There we go. Close enough. Okay, so we've got levator scap coming upward like this, from the medial scapular angle to the transverse process, posterior element of the transverse process of C1 in most cases. What that's going to do is it is going to create an alteration in scapular position. It's going to pull up that way. So what that will also do is it's going to take the glenohumeral joint here and it's going to dump it. Right, so now our position, instead of having this nice ledge here at the bottom of the glenoid rim, now we're going to have this sort of thing, where there is significantly less resistance to vertical load, right? With this pulling upward. So when he tries to go into elevation, now all of a sudden, the scapula is not going to laterally rotate, right? It's not going to do that. So what's going to happen? Let me go over here. There's our glenoid. Now we're looking at it from a lateral view, right? We will have our bicep tendon coming up and over and attaching to the top of the labrum. When this dumps downward, what we get is we get this buckling of the biceps tendon, right? It goes from being taut and flat. Now, as this dumps upward, it's going to buckle like so and become more prominent underneath the acromion, much more prone to impingement in that general region. Okay, does that all make sense to everybody? Does everybody see how that happens, how that occurs? Basically, we've got the humerus here in this position. It's going to try and swing upward, slackening off that biceps tendon, but not allowing enough tension here because this is no longer rotating, right? No longer going with it. So that's a very common mechanism for why we will get anterior shoulder pain, is increased tone through the levator scap. So realistically, what's our treatment here? Our treatment here then forces us to go in and do a cervical spine examination and determine why we have a facilitatory effect on that levator scap. So with this particular patient, I asked him if he'd had any previous trauma to the neck, if he'd been in any car accidents. He said yes. About 3 years earlier, while at work, he was rear-ended, missed about a week of work with a sore neck and some headaches. After about a week, it got back to the point where he was comfortable enough to go back to work. Had some continued discomfort in the neck, but it wasn't anything terrible. Managed to shake it off in about 3 or 4 weeks, which stands to reason pretty normal for sort of that kind of initial tissue irritation after a trauma. That went away. And then later on, a couple years later, he started to develop more unilateral neck pain, which was more consistent with sleeping on his stomach. Again, head turned to the left side. That was more irritable for him. And then more recently is when he started to develop these shoulder issues. So what ended up happening with this patient was he had a right C2-3, 2-3, come on, 2-3 traumatic arthritis. Okay. After a period of time, that right C2-3 segment scarred down, right? It constricted, capsular pattern, wouldn't move. So now the right side is no longer moving while he moves the head. So what happens is, instead of the axis of movement being in between the two segment, in between the two facet joints, now we're pivoting around that stiff joint on the left side. Left side becomes hypermobile, particularly into extension. That hypermobility creates that same nociceptive feedback. Even if it isn't painful, it's still going to start to begin. But in this case, it was painful, which is going to facilitate that levator and create the scapular dyskinesia that caused the impingement problem. So that's essentially some of the processes that you have to learn to go through as far as finding etiologies, right? A lot of different dysfunctions here, a lot of different things that can kind of come into play as far as what can affect the shoulder girdle. Okay, but that's more or less my process when it comes down to it, guys. Is I'll typically look at the CT junction first, then I'll look at the AC joint, and then if I have to, I'll go back and look at the cervical spine later. Again, the cervical spine to me is a whole giant can of worms that I don't want to have to go into if I don't have to. But that is essentially the process. So again, we're going to get more into this stuff as we go along. I know Jim has more cases, more scenarios, kind of outlined in some of his flow sheets, his algorithms that should help going along with that sort of stuff. But that's essentially the process. Let me get back to some of the chat stuff here. So scap quads. No, Jenna, like I was saying, the scapular quadrants are something that you're going to learn on this module 6 course. And Tanner is correct. The quads are in your thighs. Last I checked. So Zach, the treatment was I had to go in, I had to treat the right C2-3. Right. And so since I'm dealing with a post-traumatic arthritis, at this point, it's chronic post-traumatic arthritis. It was definitely going to be more progressive mobilization and activation of the musculature around the region in order to alleviate pressure on the left side. Then we went in and we had to give him a particular exercise routine to help protect the left side. He also had some CT junction dysfunction. He had a bad T3, actually, it was, that wasn't extending very well. Did have to do a little work on the AC joint. Again, these are some of the things that you're going to learn how to do as you go through. So basically what we want to do is we want to just restore normal biomechanical movement, normal scapulothoracic, scapulohumeral rhythm throughout the shoulder girdle. And it just is a matter of where the dysfunction is in order to decide what you have to do in order to do that. Does that mean correcting a C2-3 post-traumatic arthritis on the right side, or does that mean manipulating a T2 on the left side? Does it mean manipulating the AC joint? Does it mean doing passive mobilizations to an old sports injury on the glenohumeral joint? It could be any number of these things, and it could be several of these things in the same patient. But essentially what you're trying to do is just restore that normal rhythm, that normal movement pattern. And that should help alleviate any of the potential pressures, particularly in this patient, because he was getting a mechanical compression. So as soon as we started getting that stuff fixed, it took about 4 weeks. So I saw him 4 times over 4 weeks, once a week, and checked in with me again, I think 3 weeks after that, just to update some exercise routines for it. And he was fine, no problem. Any other questions? I got like 1 minute. No? All right, then. We'll talk to everybody again next week. I'm sure we'll have some more of this stuff that we can go through. We can probably get back into some of Jim's stuff, look through some of his algorithms and go from there. All right. Everybody have a good week.